Welcome to the Good Hormone Health webinar on May 17th, 2020. And today's talk is life for those with no adrenals. And we have a lot of patients from the Bilateral Adrenalectomy support group, and we have some Addison's patients too, and probably several other patients. And a special thanks. Please mute your phone if you're not ready. Thanks to Moxie Melissa from Texas for suggesting the topic, for providing questions, and for the publicity. Here's Moxie Melissa 2 months after her 2 months before surgery, maybe, with me. Here's with Dr. Phillips 2 weeks after her surgery, bilateral adrenalectomy. And here's some pictures at her BLA, post-up day 13 and post-up day 16. And here's Melissa now, quite a change. And Melissa's doing well. What we will discuss tonight: adrenal hormone physiology, who should get an adrenalectomy, how do you replace adrenal hormones, what laboratory tests are needed to monitor replacement, when and how do you stress dose, what about subcutaneous cortisol versus cortisol pumps, and then we'll have times for question and answers that Melissa will lead. Glands lie at the superior pole of each kidney. There are two distinct regions: the cortex, which is on the outer side here, and the medulla, which is on the inside. The hormones that the adrenals makes are the most important one is glucocorticoids, is cortisol. The mineralocorticoid, which controls your electrolytes, is aldosterone. Your androgens are DHEA and DHEA sulfate, testosterone and androstenedione. And it makes catecholamines that are also made in other tissues, epinephrine and dopamine. Cortisol has a daily secretion of about 10 milligrams per day. I'll go over that later. It has a circadian rhythm that also show, with the highest levels about 8 a.m. It comes in three forms. The free form, which is the active, it's about 5%. That's physiologically active. The large majority, 95%, is bound to either cortisol binding globulin or more weakly bound to albumin. And there's also cortisol metabolism. This shows the hypothalamic pituitary adrenal axis based on circadian rhythm and stressors such as hypoglycemia, hypotension, surgery, and fever and energy. The hypothalamus secretes CRH. It also secretes vasopressin. These act synergistically at the pituitary along with pro-inflammatory cytokines to regulate the release of ACTH. ACTH goes to the adrenals and causes the release of cortisol. And there's feedback both at the pituitary level of cortisol inhibiting the secretion of ACTH and at the hypothalamic level of cortisol inhibiting CRH. There's another axis that's crucial to our story today is the renin-angiotensin aldosterone axis, which is the mineralocorticoid axis. Angiotensinogen is a large precursor molecule of 452 amino acids. It's made by the liver. In the kidney, there's a conversion from pro-renin to renin, and then renin cuts the angiotensinogen to angiotensin 1, which has 10 amino acids, and angiotensin converting enzymes in the lung and the plasma. And of note, this is also involved in the COVID-19 binding to its receptor, this enzyme. Generates angiotensin 8 amino acids. The angiotensin 2 binds the angiotensin 2 receptor in the adrenals and the vasoconstriction, which helps raise your blood pressure. It binds to the it causes the adrenals to secrete aldosterone, which helps raise your blood pressure. So somebody with no adrenals will be missing in aldosterone, or will be missing in their mineralocorticoid axis, and it will have compensatory increase in their renin unless they are on proper doses of aldosterone or fludrocortisone. This is an old picture from Dorothy Krieger, who was with me at Mount Sinai in the 80s, showing that the cortisol and ACTH have a circadian rhythm, with the ACTH, the cortisol highest at about 8 in the morning. The cortisol declines throughout the day. There is some other spikes of cortisol. How's the sound now? With cortisol having little spikes throughout the day and with a nice circadian rhythm, so the levels are low. at nighttime. Different types of glucocorticoid insufficiency. For example, what we're talking about today is patients with bilateral adrenalectomy, and also with other causes of primary adrenal insufficiency, such you have glucocorticoid and mineralocorticoid insufficiency, and you have a compensatory rise in the pro-melanocortin molecule, which is the precursor for ACTH. The pro-melanocortin molecule has alpha MSH in it, which leads to hyperpigmentation if it's not proper. The sound should be working. I think it's probably on your side if it's not working. They have secondary cortisol, central adrenal insufficiency, is patients that have a pituitary. These patients have glucocorticoid insufficiency only.
The sound has been okay on my side.
Okay. Yeah, I think it should be okay.
I would suggest people refresh their browser if they're having issues.
Right, that's what it is. Okay. That sounds pretty loud and clear now. So we're talking about different types of adrenal insufficiency. Patients with bilateral adrenal insufficiency, adrenalectomies have primary adrenal insufficiency. Patients with secondary adrenal insufficiency have glucocorticoid insufficiency only. They don't have mineralocorticoid, and patients with glucocorticoid withdrawal have glucocorticoid insufficiency only. Some of the symptoms of glucocorticoid insufficiency, as more and more of these patients, the most common issue is GI issues, diarrhea, abdominal pain, trouble with digestion, diarrhea, nauseousness. These are most common. And if your patient has adrenal insufficiency, most likely this problem is due to a cortisol problem. It's not a GI problem. So many of my patients say they're going to go to a GI doctor. They don't find anything. So this is really a common issue with glucocorticoid insufficiency that I think is underappreciated. Patients can also have fatigue, vomiting, diarrhea, anorexia, malaise, muscle and joint pain, abdominal pain, weight loss, low blood sugar, hypoglycemia, and low sodium, SIADH. Now, the other axis, again, we talked about is the mineralocorticoid axis. They have a different set of symptoms, and it's very important to try to tease out whether you have both either a glucocorticoid insufficiency or mineralocorticoid insufficiency. So mineralocorticoid insufficiency include decreased intracellular volume. You have tachycardia and palpitations, and similar to the issue with the GI issues, most palpitations are due to hydrocodone or fludrocortisone and are not cardiac issues. You could have low blood pressure, dehydration, eventually lead to shock, low sodium and high potassium. The high potassium can lead to arrhythmias. You can get acidosis, and you commonly get salt craving. Salt cravings are very important symptoms of corticoid insufficiency. Laboratory findings of patients with primary adrenal insufficiency that are not properly treated: hyponatremia, hyperkalemia, high potassium, low blood sugars, high white blood cell count, eosinophilias, high eosinophilias, and you have a normocytic, normochromic, which means your MCV and your indices are normal, but you still have an anemia. Common also as a cause of anemia. So we'll skip it. Next topic we're going to talk about is who should get an adrenalectomy, and I think to address that, you have to address the treatments for Cushing's disease. The most common treatment that is recommended, and I recommend it, is transsphenoidal surgery for your pituitary. Sometimes it's abbreviated as TSS. The second option is medical treatment. If patient fails their initial surgery, you can do repeat surgery. You can do a bilateral adrenalectomy or BLA, and you can do radiation therapy that I'm not going to talk much about today because I rarely use it. It takes a long time to work and may give memory problems. I don't see too much of a reason to do that over bilateral adrenalectomy. We'll talk briefly about medical treatment of Cushing's disease. I've had talks on this before, and we can talk another day on that. The treatments would be ketoconazole, which I'm a big fan of. I think it's the best. It has a short half-life. It's inexpensive. It's very benign. It works very well. Korlym, or RU46, is a nice drug that blocks cortisol, the receptor. However, it's easy to get adrenal insufficiency. It's hard to monitor and hard to correct the adrenal insufficiency. Another medicine that works sporadically is corbergoline. It really doesn't lower the cortisol in most patients. Another drug that's heavily touted, but I don't think it's that good of a drug, is pasriotide. It's a somatostatin analog. It has a lot of GI side effects, including diarrhea and sort of gallbladder area pain. And it gives most people diabetes, so I don't think that's a good option. It doesn't work that well either. There's a new drug called Isturisa, which blocks the 11 beta hydroxylase enzymes and is similar to mepteroprone. I'm concerned that this one also give people adrenal insufficiency, but I'm starting to use it in a few patients, and we'll see how it works too. So who should get a bilateral adrenalectomy? The people who failed initial pituitary surgery. I don't recommend a bilateral adrenalectomy first. It has much more complications, and you are on cortisol the rest of your life. Well, if you take a pituitary surgery, many people, I would say about 70 or 80%, are cured from their initial pituitary surgery. So somebody who failed their initial pituitary surgery and there's no target for additional surgeries, I don't believe in the surgeon going in blindly to the pituitary. So if somebody doesn't have an imaging that shows a target, and I often have the neurosurgeons read the MRI, I would probably not go for a second surgery or a third surgery. I would do a bilateral adrenalectomy. Patients, again, do pretty well on medicines, but many patients want a more definitive treatment. They're breaking through the medicines, they're having side effects. So the patients that want a more definitive treatment, we'd recommend a BLA. I would agree that there are more, your cure rate is lower with more pituitary surgery. Each time your chances are a little bit less. The more surgeries you have damage to your pituitary. This could lead to fertility implications. While if you do a bilateral adrenalectomy, say after the first surgery, your pituitary hopefully is fairly intact. Some of my patients get have on the pathology what's called pituitary hyperplasia. There's no discrete tumor. It's just a diffuse enlargement of the pituitary or pituitary cells that stain for ACTH. These are harder to cure if the pathology shows hyperplasia, and many of these patients. So the pluses and minuses of BLA. I'm glad people, so again, people who can't hear should hang up and call back. I'm glad it looks like it's working now. The pluses of the BLAs, it cures people right away, and it cures people all the time. So those are big pluses. Pituitary surgery is more of a chance of not working, and radiation medicines, delay. This works pretty well. However, I'm finding about 10% of the people get what's called adrenal remnant tissue formation with recurrence. I'll talk about that in a second. I submitted a paper on this. And these patients can have a bilateral adrenalectomy. They can be tapered off their hydrocortisone, and they're still having symptoms of Cushing's or be on very low doses of hydrocortisone. So this is concerning. I think it's going to be somewhere about 5 to 10% of the patients may develop this. It's not really reported. That's why we submitted our paper on this. So that's a concern. There's a syndrome called Nelson syndrome, which happens. The pituitary overgrows because you don't have feedback. You have increased ACTH secretion. I don't think I've seen this, and I think I've had about 60 patients with a bilateral adrenalectomy. I haven't seen this at all, but I do recommend follow-up pituitary MRIs, especially if patients start getting hyperpigmentation. I look at their ACTH. If their ACTH 1,000, I would be worried about that. And I would say one patient at least had high ACTHs. We found something on our MRI, but it was a fairly small tumor. We took it out, and then her ACTHs went down. So this doesn't necessarily mean you're in real bad trouble. If you get Nelson syndrome, you just need to follow up your MRIs and may need surgery. The obvious downside of a BLA is you're on glucocorticoids, which is usually hydrocortisone, and mineralocorticoids, fludrocortisone, for the rest of your life. And you're much more likely to get adrenal insufficiency or adrenal crisis than somebody who just has pituitary surgery. So because you're missing both your axes of the mineralocorticoid and the axis, you're more likely to get pituitary surgery. You're more likely to get adrenal insufficiency, which can be much more severe. So the decision to do a bilateral adrenalectomy is a serious one. I usually try to discuss this several times with the patient before I give the go-ahead. And I think most patients that did have the BLA feel like they made a good choice. Maybe we'll open that up to questions afterwards. I don't have anybody that regrets it. Anything's worse than having Cushing's disease, and most people who had a bilateral adrenalectomy do quite well, and very few of them get any of these complications, get adrenal insufficiency. So adrenal remnant formation is the way I define it. If the adrenal tissue is confined to the adrenal bed, it is considered adrenal remnant tissue. While if it's outside the adrenal bed, somewhere other parts of the body, it is considered adrenal rest tissue. My student Julian and I submitted a paper to Hormone and Metabolic Research. Unfortunately, it was rejected by some other journals. We found that 10 of 51 patients who underwent BLA had adrenal remnant or rest tissue marked by detectable endogenous glucocorticoid production. 9 of the 10 had symptoms, signs and symptoms of hypercortisolism. The localization and treatment proved difficult. First indication occurrence is a reduction in glucocorticoid replacement with symptoms of hypercortisolism. And if this occurs, endogenous cortisol production should be tested using highly specific cortisol measurement assays while the patient is either taking dexamethasone, which doesn't cross-react with a cortisol assay, or not taking glucocorticoids at all. So Melissa asked me about BLA surgery and hospitalization. Most of the cases are done laparoscopically through a retroperitoneal approach. This is a little diagram here of what it looks like. A few very obese patients may need to be done with open surgery. I haven't found that to be the case. I send most of my patients to Dr. Chang, Chiang, in Wisconsin. He does a great. Patients are hospitalized about 5 days. During surgery, they give you IV hydrocortisone after surgery. Usually starts on post-op day 2. I usually let the surgeon decide what doses he does. I usually have the patients discharge somewhere between 30 and 50 milligrams of PO hydrocortisone and fludrocortisone 0.1 milligram twice a day. I don't like this high doses that some doctors recommend. The high doses impair wound healing and are usually not necessarily. If I do a little bit more than 30, I'll have them taper down pretty fast to that. I get a set post-op day 7 DHEAS to show that the adrenals are completely removed, and I get electrolytes. And then approximately on day 22, I get an ACTH, which should start being elevated by that time. A renin, which we'll talk about in a second, is a very good indication of the dosing of the fludrocortisone, and a 24-hour urine on the hydrocortisone to try to monitor the hydrocortisone dosing. The ACTH should be between 100 and 1,000 in patients on proper glucocorticoid replacement. And the plasma renin activity, or renin, is the most important test for BLA patients and for Addison's patients too, and guides fludrocortisone dosing. So I find that most people don't get enough renins checked, and this is a crucial aspect. So in terms of treatment, in terms of quality of life, the proper replacement is the key. Many people, both too much and too little are bad, and you have to adequately replace both the hydrocortisone and the fludrocortisone. If one of them is off, then you have problems with the not feeling well. And again, too much or too little can be. Melissa asked me, is there any literature on quality of life? There are several articles, but I did pull up this one that was a postal survey of patients with primary adrenal failure from Norway. A scale called the SF36 was used to assess subjective health status. 79 of 97 patients responded. We can probably for overall health. Perception were most consistently impaired in the patient with Addison's disease. Scores for fatigue, both physical and mental, were also higher than normal, i.e. the patients had much more fatigue. And 24% of patients in the 40 to 67 range were out of work and receiving disability compared to the control population. So about, 2 to 3-fold more people are out of work and on disability in Norway. So how much cortisol is made? When I was at the NIH, a colleague there wrote a paper named Dr. Esteban with most of my colleagues at the NIH that measured daily cortisol production in normal volunteers using a stable cortisol method. This is a widely cited paper. The average was about 10 milligrams a day. More on too much of that. I think as I've been treating patients with Addison's, the rest of the community has caught up with this, and the replacement dose is much lower than it was 20 years ago or so. And most people are now getting sort of between 15 to 20 milligrams a day. Too much glucocorticoids leads to osteoporosis, glucose intolerance, diabetes, increased infections. I think if you're properly replacing, somebody needs to be muted. Everybody mute your phone if you're not already. Thank you. So the main problem I see is people don't absorb the cortisol right, and it's properly, and it's a vicious cycle. Cortisol is needed for absorption. So if you have poor, low cortisol, it's not being absorbed, then you don't absorb well, and it gets worse and worse. So I see this malabsorption issue as the key issue in replacement, and we'll talk about ways to get around it. Some people, you just give them a little bit more, they're able to be okay. Some people, you have to go do a non-oral route. Physiological equivalents of glucocorticoids are listed here. 20 milligrams of hydrocortisone is sort of the standard. That's shorter acting. That's equivalent to about 15 milligrams of IV or subcutaneous Solucortef. It's equivalent to about 4 to 5 milligrams of prednisone, which is longer acting. 4 milligrams of methylprednisolone or Medrol, which is longer acting also. And dexamethasone can come in either pills or liquid, is about 0.75 milligrams. I like the liquid dexamethasone that comes at 0.5 milligrams for 5 mLs because it's easy to titrate. It's longer acting, but it has no mineralocorticoid activity. So if I'm switching somebody from hydrocortisone to dexamethasone, I do increase their mineralocorticoid replacement. And each of these is good. There's no studies comparing one is. It seems to be sort of how people metabolize the cortisol. Some people are faster metabolizers, and they feel like they're burning through the cortisol, and then a longer one might be better. Other people like the shorter acting one because they don't want it to last all day. So I usually start with hydrocortisone and use it in about 90% of my patients. I like it because you can monitor, and we'll talk about this later, with urinary-free cortisol or 17-hydroxysteroids or salivary cortisol day curves. You can't do that with prednisone or dexamethasone. And then I would try the other ones, prednisone, Medrol, liquid dexamethasone, sometimes combinations. If somebody's saying they're feeling high a certain time of the day and low another time of the day, I'll try to vary about when I give them the different doses of hydrocortisone. And if somebody's like feeling low overnight, we might give them a little prednisone or dexamethasone before they go to bed. So there's different combinations we can try. In terms of glucocorticoid replacement, most patients are overtreated. The earliest although I think that's coming down, but my patients aren't. The earliest manifestation of excess treatment is easy bruisability. They can have weight gain, central obesity. The earliest manifestation of inadequate treatment is joint pain, nauseousness, and abdominal pain. It's reasonable to mimic the circadian rhythm with most of the cortisol given first thing in the morning. Some people burn through cortisol more and need multiple doses throughout the day. You want to avoid doses of cortisol at night, but you do need a small dose usually. And some people need some cortisol to go to bed. I'll show my data on that in a second. And there's no studies comparing different treatment regimens. So in 2000, when we published a paper with Dr. Garcia Borraguro, this is from our work at the NIH, where we did sleep studies in Addison's patients. And we found out that in Addison's patients, cortisol plays a positive permissive role in REM sleep. You need some cortisol before you go to bed to go into these deeper stages of sleep, and they help consolidate sleep. And this suggests the need for low-dose hydrocortisone, either 1.25 milligrams, which would be a quarter pill, or 2.5 milligrams at night. So my approach is to start with hydrocortisone mostly in the morning, aim for about 15 to 20 milligrams a day in women, maybe slightly higher in a male. 10 to 15 milligrams in the morning, 2.5 to 5 milligrams in mid-afternoon. Sometimes they give another dose at about 5 p.m., and they usually give 1.25 to 2.5 milligrams at bedtime. The hydrocortisone is more physiological than the prednisone or dexamethasone. I decrease slowly until symptoms develop and then we'll go back a dose. Small changes make a huge difference. It has to do with how much binds to the glucocorticoid receptor and the binding proteins. So you can make a little change and people will often do much better. Or if you go too low or too high, people will do much worse. In general, I encourage people to increase it with illness. Short term, it's better to err on giving more. Long term, it's better to err on giving less. And the dosing is crucial. There probably is some difference between brand and generic, although I think the Cortef brand and Greenstone are both very good and very similar. Hydrocortisone is generic, Cortef is brand. If you just order hydrocortisone without mentioning the brand, the pharmacy can substitute different suppliers without telling the patient or the doctor. I like Greenstone the best. Other good one, Core Pharma is good. Qualitas and Westward, I think, are a little less good. Hydrocortisone comes 5, 10, and 20 milligrams. I usually give people a 20 and a 5. I think the 10 is cheaper, but if you're trying to do a quarter of a pill or half a pill, the 5 is very important. So I usually give people a lot of 5 milligrams. Stick with maybe April, but I don't think that's really true. And I think the hydrocortisone is pretty readily available now. Mineralocorticoid therapy is probably more important because people don't sort of ignore it. And it's needed in primary adrenal insufficiency. I start with fludrocortisone, and the dose of fludrocortisone varies between 0.5 milligrams to 0.5 milligrams. People need a fairly similar amount of hydrocortisone, but the dose of fludrocortisone varies greatly. I think it's very important to give it twice a day. Most endocrinologists don't do this. Most review articles or recommendations don't recommend this, but it has a pretty short half-life of 3.5 milligrams, and you don't give hydrocortisone once a day. You should give fludrocortisone once a day. I find people do much better with it twice a day. A starting dose would be 0.05 milligrams, a half a pill twice a day, and you titrate based on the renin levels. The renin is high, you need more. The renin is low, you need less. The fludrocortisone generic, there's a couple different brands. Teva and Impact are the two main ones. People often need more fludrocortisone in the summer when they're sweating, especially if they're in a warm environment. There was a shortage in late 2018, as far as I know. That's been corrected and there's no problem now. People should get a Med Alert bracelet. And and there's also, most phones have a health tab that people can check your health without turning on your phone. I think that's probably a good choice nowadays, and when people are much more digital, to put this in your phone. Then people should get a supply of Cortef for emergencies. It comes in this vial called an Acto vial. You give yourself a shot if you need it, and this is very important. How do I monitor glucocorticoid replacement, mostly signs and symptoms? I often do a 24-hour cortisol and 17-hydroxysteroids. The UFC is usually a little bit higher than 17-hydroxysteroids. It's probably pretty good per day. If people can hold off the questions till the end, also that would probably be helpful. So then I can answer them all at once. The UFC may be a little bit high in some people that are on proper replacement. 17-hydroxysteroids is pretty good, but I do look at both of them. And the 17-hydroxys reflect your cortisol metabolism throughout the day. They can be done on the same sample collection. There are a lot of people that advocate these serum or salivary cortisol day curves. What's called a cortisol shuttle, that during the day cortisol goes into cortisone and then it gets released back into the tissues where it's active. So I don't use it that much, but you can sort of give that. You can do them sometimes. Patients that really can't figure out if they're sort of high or low at a certain time, I've been using it some. One of the patients I talked to today, I did that. So I think these salivary cortisols are probably not that helpful, but some patients I use it in. The ACTH should be high. It should be between 100 and 1,000, unless if it's less than that, I'm a little concerned that people are over replaced. Unless people had a lot of problems with their pituitary, if they had several pituitary surgeries, the ACTH may not be so high. And if the ACTH is greater than 1,000, I get an MRI to look for Nelson's. How do I monitor mineralocorticoid replacement? The renin activity, plasma renin activity it's called, is very accurate, should be measured every 2 to 3 months. The tube should be chilled and spun right away. If it's high, you give more fludro. If it's low, you give less fludro. Electrolytes are much less sensitive. Most people have altered renin, but normal electrolytes, so I don't get electrolytes that often, but it's probably good at times. I've had several patients that their doctors have stopped their fludrocortisone because they've had high blood pressure. I don't recommend that. If the renin is normal, stay on the fludrocortisone, but give a blood pressure pill. I think somebody asked the question, does everybody with adrenalectomy need fludrocortisone? The answer is most definitely. I don't think you can be, you might need a very low dose, but everybody does need it to be titrated based on the renin. So it's very important if you do take blood pressure, what blood pressure medicines to take. The best ones, I think, are the calcium channel blockers. Amlodipine, which is also called Norvasc, or diltiazem, which is called Cardiazem, would be my top choices. Don't give ACE inhibitors. ACE inhibitors, you need an active angiotensin aldosterone axis, so benazepril, citabol don't work. ARBs are really bad, and spironolactone is really bad because they block the glucocorticoid activity of, they block the mineralocorticoid activity, but not the glucocorticoid activity. So people would have will get some glucocorticoid activity from their fludrocortisone, which is not good. So it's really good not to, you should not take an ACE inhibitor, ARB, spironolactone, or diuretics. What about salt and licorice? I think people should use salt abundantly, especially if you're salt craving. You could take a little bit more before exercise. As long as you don't have heart problems or hypertension, you can take as much salt as you want. You'll just irritate it out if you don't need it, but a lot of people do need salt and helps them. Licorice binds to the 11-beta-HSD enzyme, allows more cortisol to bind to the cortisol receptor in the kidney. And this is probably a good way to get more mileage from your cortisol and fludrocortisone. I haven't seen much problems in it. It does have a little bit of an estrogen effect. So, you know, it might raise your estrogen levels a touch, but that's probably okay anyways. And you have to watch your electrolytes with it, but it's usually a good choice. And I like licorice root from Nature's Way, 450 milligrams twice a day. DHEA is only made by the adrenals, so if you don't have any adrenals, it should be 0. I recommend 25 milligrams a day. It may help with the energy and immune system. I don't think it's essential to take. Some people don't take it and they do fine. Too much DHEA can lead to oily skin, oily hair, and acne. Testosterone is made half by the adrenals and half by the ovaries, which is regulated by the pituitary. So patients that had a BLA prior pituitary often have low levels. I usually give it by a compounded cream. The dose I usually give is 2.5 milligrams per mil, 1 mil daily. It may help with energy, muscle strength, and libido. I think it has less side effects than DHEA, so I tend to use it more than DHEA, although I think people with adrenalectomies should probably be on both. It can give extra hair growth and acne as our main side effects. Melissa asked me to talk about a typical hormone panel. Probably should be get every 2 to 3 months before your appointment. The renin's crucial. You could be sitting. I don't think you need to be standing. Chilled tube spun immediately. The same with the ACTH. Chilled tube spun immediately. DHEAS electrolytes. You probably get them every 6 months. Bioavailable and total testosterone. If you have a pituitary problem, you need to monitor your pituitary hormones such as IGF-1, your thyroids, free T4, free T3, TSH, and reverse T3. Estradiol or other gonadal hormones is needed if you're having pituitary problems and menopausal issues. Probably doing that 24-hour urinary-free cortisol 17-hydroxysteroids while on replacement tells you again how much is absorbed. I think you do that every 6 months. No need to measure cortisol. It should be 0 unless this remnant tissue. If you have the remnant tissue, we'll talk about that at another time. Then you may need to measure cortisol. I don't usually do imaging unless, again, we're concerned about remnant tissues. You don't need to, or you really can't measure the things like dopamine. Dopamine's in the brain for the most part. Catecholamines, it's not really helpful. The measurement's not that good, and the replacement's not that good either. So I usually don't measure those. Can someone with adrenal insufficiency get these? Yeah, flu shot. Yes, I think people should get a flu shot. Steroid injections, if you have back problems, yes, but trying to minimize the duration. Oral steroids for asthma, yes, but minimize the duration. Steroid inhalers, yes. Steroid cream is probably okay. If and when the COVID-19 vaccine comes out, probably should get that. I don't see why not, certainly. Hopefully that will be soon. I talked about this in my last lecture, but the COVID-19 and stress dosing, who should stress dose? If you're just concerned about getting it, or if you had a contact with somebody, but you're not sick yourself, I would not stress dose. If you are infected with it, but not sick, I would not stress dose. But if you start getting sick, shortness of breath and sick, stress dose and go to the emergency room. There was an endocrinology statement, an ACE guideline about sick day rules as relates to COVID-19. Any patient with a dry continuous cough and fever should immediately double their dose and continue on the regimen until the fever has subsided. I'm not sure I agree with that. I think if somebody has a cough and a fever with COVID and with adrenal insufficiency, I would probably go to the emergency room and see if you need to get admitted. I think it's a serious enough condition that I'm not sure people should just ride it out. But if you're slightly sick and not short of breath, you can stress dose and stay at home. But I think most of these patients should go to an ER or urgent care, and at least get a pulse oximeter tested and see their oxygenation. In terms of stress dosing, make sure you drink fluids and take in a lot of salt. I would stress dose by doubling your hydrocortisone. Dr. Friedman, in his editorial, thought you should triple the dose. I think too much is like triple is too high, and you do worse. I was quoted in Endocrine Today on this, and I have an Adrenal Crisis letter at the top of my website. You can look at the slides and download these. There's links, hyperlinks to both of them. Adrenal insufficiency in the immune system. Patients with properly treated Addison's disease still have an impaired immune response due to a T cell problem, but people with central adrenal insufficiency or bilateral adrenalectomies are probably not in this category. So if somebody with a BLA is properly treated, I think their immune system is probably fairly close to normal. Patients that are undertreated may do worse with infection, but over patients are likely to do much worse. So I would probably, again, err on being try to be properly treated. If anything, be a little undertreated and not overtreated. And in general, unless you're sick, don't stress dose if you think you're going to get sick or something like that. In general, for stress dosing, I think short-term it's okay. Try to avoid creeping up on your dose. Some people stress dose every day and they end up being on a high dose. They can't cut down. Fever and vomiting are certainly reasons to double your dose. If you're under a lot of psychological stress, you can add an extra 5 milligrams. Exercise, before you exercise, it's reasonable to add 2.5 to 5 milligrams of hydrocortisone, half a pill of fludrocortisone before. Some women need a little extra hydrocortisone around their menses. I think that would be okay also. Adrenal crisis, it usually happens in patients with primary adrenal insufficiency, not with people with participated by stress, either emotional or physical, is quite common. You have new patients, obviously, but you have patients that are established patients, either stopped or ran out of medicines. I doubt anybody on this call is in that category. Illnesses, GI issues, stomach flus are really nasty. Upper respiratory infections can throw people off. I'm concerned when somebody has a stomach flu and they can't keep their pills down, they're vomiting. That would be more time to be more concerned and give yourself some Solucorta. The symptoms are GI issues, nauseousness, vomiting, abdominal pain, diarrhea, fatigue. You can get high or low blood pressure. Your body goes into like a flight or fight response. Your blood pressure often goes up. Your pulse is often high. You feel weak. You feel like you're passing out. That's not a good sign. You feel like you're not circulating your blood to your body. That's not a good sign. All those would be dangerous. Do something. People should try to know when it's coming on. I think people that have had a BLA for a while sort of can pick it up and head it off before it comes. Start by doubling your dose. If you still have that, do 100 milligrams of IM hydrocortisone, take extra fludrocortisone and salt and extra fluids. Go to the emergency room and bring a crisis letter, but be prepared to wait. And I'm not sure, most ERs probably don't know as much as the patient does on this. So you may have to guide your ER doctor. But if you need to go, you need to go. So try to be judgment and really be smart and know your disease and know how to treat it. Illnesses or surgery. For moderate illnesses, 50 milligrams hydrocortisone twice a day. Severe illnesses, 100 milligrams of IV hydrocortisone every 8 hours. Minor procedures without anesthesia, dental work, for example, no extra coverage. Colonoscopy, this is very important. The prep is worse than the procedure. So the day before the prep, the day before the procedure, on the prep day, double your hydrocortisone and your fludrocortisone, and do it also on the day of the procedure. Moderately stressful procedures like endoscopy and arteriography, single dose of IV hydrocortisone before the procedure is reasonable. Major surgeries, 100 milligrams before anesthesia every 8 hours. Next day, double your dose. Most people, though, I think I recommend 100 milligrams IV before and after the surgery. Next day, double your dose, and then go back to your regular dose. We're going to close by talking about pumps and subcutaneous cortisol. I've started just fairly recently using a lot more subcutaneous cortisol. I use it in patients with GI issues that can't absorb the hydrocortisone. The Solu-Cortef comes in sort of two areas, and I'm glad Melissa pointed this out to me. There's in the active 100 milligrams, it gets reconstituted in 2 mils, so the concentration is 50 milligrams per mil. You can also get a Solu-Cortef powder that you reconstitute in 1 mil, so it's 100 milligrams per mil. That may make it easier to calculate. I've seen, but I haven't had any patients that have been really successful getting it, at least online. It says 500 and 1,000 milligram vial. I usually dose it 3 to 4 times a day, similar to the oral hydrocortisone. So if somebody's on oral hydrocortisone, I would switch them 101 to the subcutaneous hydrocortisone, the subcutaneous Solu-Cortef, and then you could probably taper down the dose slightly because it's better absorbed. And I would recommend this to try this before trying pumps, because I think this is probably just as good and much easier than the pump. There's been several articles on the pump. I'll just pull up one from 2014. The objective of this study was to compare subcutaneous hydrocortisone infusion with conventional oral hydrocortisone replacement therapy. They found no significant difference between treatments, the oral versus the pump, in weight, waist to hip ratio, blood pressure observed, although there was a tendency to increase weight and body mass index, or weight, with the infusion or the pump. Morning glucose levels increased with the pump and were significantly higher on the pump than on the orals. There was no difference in sleep parameters. So if some of my patients are on the pump and love it, they can certainly be used. I've heard patients getting infections on the pump. You need to use an insulin pump. The most common brand is Medtronics. Insurance companies really don't know how to process this. They keep on asking me, what's the dose of the insulin the person is taking? And we have to tell them back all the time it's used for hydrocortisone. So this is definitely an option. You can use a Solu-Cortef powder reconstituted 100 milligrams at 100 mils, so it's 1 milligram per mil. This may be able to lower the high ACTH. That doesn't happen if you're on pumps. And you can get some delivery overnight. In general, the literature seems to say there's a little less fatigue, but some weight gain with the pump. And I would reserve the pump to those who failed oral hydrocortisone and at least one other steroid preparation. And I'd probably recommend subcutaneous Solu-Cortef first. Typical pump dosing is about 25 milligrams per day from 8 to 10 a.m., 1.8 mils per hour. From 10 to 2, 1.2 mils per hour. From 2 to 8.5 mils per hour. From 8 to 4, a much lower dose, 0.25 mils per hour. From 4 to 8 a.m., back to the 2.5 mils per hour. The Solu-Cortef should be at the 1 milligram per mil, so you can convert these to milligrams easily. Okay, so that was pretty good, I hope. Thank you for joining us. We're going to open up the chat questions. If you have more questions after tonight or want an appointment, please email us here. My website, as people know, is go to hormonehealth.com. The webinar will be posted in a few days. And let's go to the chat questions. Let's try to see what we missed a lot in first. Okay, Allie says she's having Nelson's and having surgery again. I think that's it can happen again with some people. So you just need to have your surgery. Hopefully that will cure it. I've been told I have Nelson's. My ACTH was over 2,000. Been told I have a remaining tumor with 2 doctors suggested radiation. However, my local doctor in Missouri said there's no growth. What should I do? Very dark. To me, you have to have someone carefully look at your MRI. And it sounds like it should be removed with surgery if possible. If there's sort of like a vague reading, radiation is reasonable here. How do you know if there's an absorption? So you have your hydrocortisone goes, it's not helping you. And you're having a lot of GI issues. Blakely asks, I'm preparing for my BLA on the 28th. What are things I should do to prepare for my surgery and recovery at home? I think you need to get your hydrocortisone and fludrocortisone ordered. You should have lab tests for afterwards, set up an appointment with your doctor, your endocrinologist afterwards. I often put people with, pretty florid Cushing's on ketoconazole to try to lower their cortisol before surgery. That may help you heal better. That would be a possibility. Check. Okay. Since osteoporosis can develop with Addison's, at what age do you recommend a bone density? Um, I think when you're diagnosed with, when you have your adrenalectomy, it's probably reasonable to do it, and then maybe every 5 years. I also like a test called a urine peptide, which is a second urination in the morning and looks at bone turnover sort of actively. The bone density is over your whole life. The peptide tells you what happens now. A high level means you're turning over bone, and that would be more of a concern to go on a osteoporosis medicine or try to cut down your hydrocortisone. And I like vitamin K2 for Moxie Melissa says the bone test is called a urine peptide. And I like that. And I like giving people vitamin K2, 150 milligrams twice a day, 150 micrograms twice a day for the bones. I think it's a good starting point. The other osteoporosis medicine I use is Fosamax or Lindronate. There's other ones that are very expensive. It's hard to get through insurance, but those are the main ones. Art says, I have read that for COVID-19, some analysts suggest doubling the morning dose, then 20 milligrams, 6 hours, and then since it's such a bad infection. Again, no. I would say if you're not sick, stay on your regular dose. If you're sick, go to the hospital. If you're just a little bit of sick, then just double your dose, for a short period of time. Too much is worse than too little in general. Jeannie says, let's see. Jeannie says, do people with failed pituitary surgery inevitably need BLA due to hyperplasia developing on your adrenals, regardless of pituitary being removed or not? I would say no. You can treat people with medicines. You can treat people with radiation. You can, have repeat surgery. The hyperplasia is due to the high ATH, and if you can lower that with surgery or medicines, or sometimes the medicines like ketoconazole actually raise your ACTH but block the cortisol synthesis. So not everybody needs BLA. If someone doesn't need fluid, does that mean there's remnant tissue? Could be. I would again make sure you're on proper. If you take enough hydrocortisone, you won't need Florinef. But usually that it's a bad to be on too much hydrocortisone. So if you're on proper hydrocortisone, 20 milligrams, and if your renin level is normal, then you don't need it. But I've never seen that basically. Pretty much everybody does need it. Either needs a little bit of it. So really let the renin guide you and be on proper dose of hydrocortisone. How is Nelson's diagnosed? It usually has high ACTH and a pituitary tumor and hyperpigmentation. Do males need testosterone replacement for the rest of your life? So yes, what quantities? I would say no, because in males, the majority of testosterone comes from the testes and is regulated by the pituitary. So if you have a pretty reasonable pituitary, you may not need testosterone at all. What about the drug that was approved a year ago that builds bones? There's several drugs for osteoporosis. I'm actually not really an expert on osteoporosis. Most of these drugs are super expensive and really hard to get through insurance. Why do you prefer liquid dexamethasone over the oral pill? That's because the liquid dexamethasone, you can titrate your dose very finely. So you can get a dropper and just add a little extra droppers, a little less droppers to get the exact dose you want, while the pill just comes at 0.25 milligrams and it's harder to fine tune. What about your recommendations for follow-up blood work or other tests after BLA? Super hard to find a good doctor at home. Again, I'm always willing to help people out here. With COVID-19, we're doing patients. They don't have to come in and see me in person. I'm not sure how long that's going to last. So I think, the adrenalectomies, adrenal diseases, well, a lot of doctors don't know how to treat people properly. So I'm happy to see people. And if not, find a good doctor at home. I think there are some people that specialize in adrenal, not just a diabetes doctor. So hopefully you can find a good doctor. You're a little more at the top here. First, I don't feel it's safe for me to be around others with COVID-19. So prevalence, that's a tough question. I think I'm in favor of stay-at-home laws. I'm working from home. I'm having my patients stay at home. I think safety is important, and if you can work from home, certainly to work from home. And it sounds like this employer let you work from home initially. It's just like you still stay at home. I don't think it's that much safer June 1st than it was May 1st or April 15th. I think April was probably our highest rate of maybe new cases, but it's not dropping off at all, really. So I would try to argue that, you just keep on staying at home. One of the risk factors of COVID-19 is diabetes, which I agree with. Where did one go? Because having adrenal insufficiency put you the same higher risk or lower risk in diabetes. I would say it's less than diabetes if you're properly treated. Diabetes itself seems to be a risk, but there's also, it's hard to tell because the people that have diabetes are often, and high blood pressure are often older. And, I think I think age is one of the key things, comorbidities is one of the key things for COVID-19. And I think, again, if you're on disease, if you have just adrenal insufficiency or properly replaced, I think your risk is low. I think if you have diabetes, you should get it treated, and that should reduce you to normal risk also. I have slowly increased my number of doses and quantities over the years. I'm now 6 times a day with a base of 30 milligrams a day with up doses for exercise. I'm concerned about over replacement. So my order has ordered a blood test, serum blood test. I think a serum blood test is a complete waste of time. It's not going to tell you anything, basically. If you take it like after your dose, it will just tell you how much that dose you took. If it's before your dose, it'd be put on hold. It'll just tell you 0. So I would tape it down a little bit, especially if you feel you could. And I would do the 24-hour urines for near-free cortisol and some kind of hydroxysteroids first. You can maybe try some kind of day curve also, but I think, and make sure you're on the proper fludrocortisone dosing with a normal renin, because some people, they've gone up on their hydrocortisone because they're not feeling well when it actually was a fludrocortisone problem. Okay, Janet asks, I have secondary adrenal insufficiency. What you said applies to most people with secondary adrenal, including treatment. Why is there a distinction in BLA and secondary adrenal insufficiency? So for most people with secondary adrenal insufficiency, a pituitary problem, you don't have defects in the mineralocorticoid axis. Some of my patients do, but many of them don't. And many of the people don't, most people don't need fludrocortisone with a pituitary problem. Everybody with a BLA needs for people with pituitary problems, they have to properly replace their pituitary hormones. Paulette asks, I have a ectopic adrenal tissue, has BLA and takes no steroids and have Cushing's again. What testing do you think you do? What testing do you do if not found in any way? So you probably have remnant tissue. So you have to find that with, first of all, documenting it with testing a cortisol. You're already off of steroids, testing the cortisol levels, urinary cortisol, salivary cortisols, blood cortisols. And then if they're high, then you have to find the remnant tissue. It's very difficult to find it. I think CT scan, high quality, high resolution CT scan is probably the best. PET scans are options. There was a test called iota cholesterol scan, which is no longer being made, unfortunately. So it's a hard case. You probably should end up seeing me. Lisa, I have developed chronic hypokalemia for no reason 8 to 9 months after BLA, and now on at least 220 milliequivalents of K. So first of all, I think taking a lot of K is benign. My fludrocortisone doesn't seem to be an issue. 2 weeks ago, my K was 2.7, and an extra 40 to 220. I would make sure your renin is normal, and it sounds like maybe you're on too much fludrocortisone. So make sure your renin's not suppressed, and maybe you need to cut back or just take the potassium. I want to try Annie asked, I want to try a nighttime dose because my sleep is bad. I'm currently on 15 milligrams, 6 a.m., 10 milligrams, 10:30 a.m., 2.5, 3 p.m., 2.5. Should I take hydrocortisone away and add to the 15? And should I take it a little bit at bedtime? I would cut down on your morning dose by 2.5 or 1.25 maybe, and try the 1.25, switch shifting it to bedtime. And, taking a half hour before is okay. Moxie Melissa, well, you once said that for many people go into the adrenal crisis from mineralocorticoid deficiency instead of glucocorticoid replacement. I think that's probably true. I think it's a combination of things, but then people do worse, often do worse when they're mineralocorticoid deficient. So I think, again, it's important. Really, both hormones are important. And you need proper. Where have you had your patient's rest tissue found? So most people, it's found in the adrenal bed. It seemed to have come, where they had their adrenal surgery. But by imaging, there's a lot of like false negatives. False negatives. There seems to be people that have something that's seen on adrenal tissue that turns out to be not the case. But most of them are found in the adrenal bed. One patient was found in her ovaries plus her adrenal bed. Dehydration is very bad for us. Definitely, really, people need to stay hydrated, especially when it's in the summer. Taking a lot of salt, taking a lot of fluid. What's your take on this? I can't sleep past 3:30 a.m. unless I take a full 5 milligram of hydrocortisone. I presume that's hydrocortisone at 3:30 a.m. and also take 2.5 at 8 p.m. and 2.5 at 12:30 a.m. I would take dexamethasone or prednisone before you go to bed. 1 milligram of prednisone might be a reasonable choice to carry you through the night. I also like slow release melatonin. GMS, I had BLA 2 years ago after 2 failed pituitary transference surgeries, failed to remove the cortisol. Have had Addisons and have a hard time on hydrocortisone dosing, 0.75 milligrams plus 10 milligrams hydro and fludro. Was in the ERA after my legs falling me what is happening. Definitely get a renin level. Definitely take your fludrocortisone twice a day. And make sure everything else is properly replaced. Possibly, when you're on the DEX, it's really hard to measure the hydrocortisone. And make sure you're taking it a couple times a day. Hillary says I take fludrocortisone 0.1 milligrams split it at 0.5 at 7 and 0.5 at 3. My renin is still high, but sodium is good. Should I consider a higher dose? Absolutely. You want to titrate your fludro to a proper renin. So, go up to 1 in the morning and a half in the afternoon, and then see what your renin is, and maybe go up to 1 twice a day. Marie says, I've had 3 pituitary surgeries. I've been on Dostonex Cabergoline for 2 years for recurrent Cushing's. It's probably not doing that much. My cortisol levels are coming down in the high normal range. My Doston dose again. I'm taking 9 pills a week. I'm wondering if it's a good long-term treatment or should start looking at more options. I don't really like the Cabergoline. I think it works weekly. I would look into ketoconazole or some of the other choices over Cabergoline, to be honest. What do you think of a combination of hydrocortisone and prednisone? I think there is some instance where that helps. Prednisone is a little more aligned with fasting. You can supplement the hydrocortisone in between. Yes, what Michelle said. Thank you. Thank you so much for taking time out of your day off. It's not really my day off. I work on Sundays every day, every week, but thank you. Moxie Melissa, is renin a moment in time measurement? So a renin test a few minutes ago means nothing. I would do renin like every time you get your blood test done. Again, I think it's the most important test. Especially it has to be done correctly. And that's normal a couple months ago was a good sign, but it's hotter now and things have changed. When you change your hydrocortisone dose, you need to check your renin again. Hydrocortisone has some mineralocorticoid properties. Yes, Priscilla says, yes, when we exercise or sweat a lot, we can increase fludro. I sweat, I feel better. How do I contract that? You might just have to live with the swelling. I think and again, guide your renin levels. If your renins are okay, I'd probably you're probably on a good dose. You can add a little more salt. If tumor shows on MRI, should I consider a 4th pituitary surgery? I think so. If something's seen, I usually send people for surgery. And I've had people that have had cures after 4 surgeries. How long should I be off DHEA to get an accurate DHEA lab? So get the DHEAS test. If you're looking at remnant tissue, or if you want to just make sure you're not making 0, and I would be off it for about 2 weeks. What time of the day should I wait in the pandemic because overtime my BLA doesn't matter? I think it probably doesn't matter too much. Hopefully the hospital sterile and does a good job. What time of the day do you recommend getting blood draw? I recommend it in the morning, probably before your morning doses. If you're we're not getting ACE cortisols anyways for the most part, so that you don't have to worry about. I don't think the renin effects or your ACTH really matters if it's before or after your Fludro or your hydrocortisone. Okay, final question or comment. Melissa, do you want to close it out?
Sure. First of all, Dr. Friedman, I wanted to really thank you for spending the time. I asked for a webinar based on BLA patients. Of course, we're told we're so rare, and no doctor has seen very many of us, so it's very difficult for people who are not your patients to get all of this information, and you've laid it out wonderfully. So we really appreciate that.
Thank you so much.
I also, I see some names of those who put their names down that I don't recognize. So I wanted to invite everybody who has had a bilateral adrenalectomy as a result of trying to cure Cushing's to join us on Facebook in a group that I moderate called Life After BLA. We have over 375 people that I've screened and allowed to come in because they've had bilateral adrenalectomy from Cushing's. People from Theos and other folks always want to try to get in, but I really keep that to a BLA group because we're still dealing with the damage of cortisol that some of the other folks aren't dealing with. So we have 375 people who've had BLA and about another 125 that are kind of going through other treatments, other medications, trying to figure out how this life after BLA might work. And it's kind of a holding area in their holding pattern before they move on to BLA. So if you're considering that may be an option for you, or you want to learn more information, you're welcome to join us. Just answer the questions when you come in so that I'll be able to approve you quicker. I also wanted to tell you that we have Cushing's groups in the US by state that I've created, and I'm a moderator. I'm looking for other people to help moderate those. But if you're looking for an endocrinologist in your state, or you don't know anybody that has Cushing's in your state, you're just sure you're the only one around, we've got several people, at least in all the states. I think Hawaii's just one, and Alaska maybe one or two, but we've got quite a few people in all the states. New Jersey's got a big group, North Carolina, Michigan, Ohio, of course, Texas and California and Florida. Those are larger states, but we do have Cushing's everywhere, so they can help you try to find a good local endocrinologist. I also wanted to reiterate what Dr. Friedman had said. He is available for consultation. So if you're seeing anything that he's mentioned and you're like, hey, I've asked my doctor for that and my doctor won't test, he won't do it, I encourage you to make an appointment with Dr. Friedman. Some cases he's a BLAers only endocrinologist, and sometimes he is the second one. He's our kind of Cushing's expert, and we speak locally with endocrinologists. And even I'm going to see Dr. Friedman May 31st is my appointment because I need to fine tune some things that are going on with me. And then just really the last.
Right, and there's a lot of fine tuning involved. I mean, I think most people do okay, but if you want to do really well, if you want a good quality of life, it's all about fine tuning.
Exactly. And I've tried to emphasize to many people in the group that, nobody's going to kind of figure it out for you. We're all there to kind of share stories and figure it out. But if something's not working quite for you, you're the only one who really is going to do anything about it. You've got to seek extra help. You've got to post and ask the question, or you've got to try to get the local endocrinologist to help. And if they can't get help there, they really need to see you, because everything's about being optimized. I've made really micro changes within the last year, and I'm seeing my quality of life increase. I feel like I'm at about a 5 or a 6. So I'm still, gonna talk with you and see what else we can figure out. Again, I just wanted to really thank you people have said that I've been really helpful in the Life After BLA group. And I really wanted to share with everybody that most of the knowledge I have, I'm just repeating what Dr. Friedman has told me. So I think about 50% of my knowledge is directly from Dr. Friedman. I give 30% credit to all the other Cushing's patients I've known for the last 13 years, and then 20% for myself for digging into medical literature and just kind of reading and trying to turn over every stone and try to figure things out. So if I've helped you, I want you to know that my information, at least half of it's coming directly from Dr. Friedman. So I want to encourage you to, again, just kind of keep plodding along, but if something's not right, really take the time and try to find the best Life After BLA that we can get. So I thank everybody for joining us. I don't know if we have any other questions.
Your questions inspired me to look into some new things also. So it was also very helpful for me. And you taught me some things too. So that was good.
Okay, good. Yes, I sent Dr. Friedman a lot of questions because I wanted him to explain why does he measure DHEA. A lot of doctors don't even measure that. They don't even mention it to their patients that they might feel better on it. Some people don't need it, but it's an option. So there's lots of incremental changes and improvements that we can build upon that it's definitely worth a try. I see a nice note from somebody. They appreciate my work. That's very thankful. I'm do the best I can. I've had to take a break from the internet, from all this kind of nervousness over COVID-19 and trying to keep stress low for myself. But if you ever need anything, please post to the group, because we're an international group and people with BLAs are online a lot, 24 hours a day. And the nights that we can't sleep because we stress dose, we're up also, probably in your time zone. So always just, we find that the closer people stay to the group and asking questions and reading things, the better they are about kind of managing their health, and they tend to do a little bit better. If things aren't going well and they kind of recede from life and other patients, they don't want to deal with Cushing's, what ends up happening, frankly, is you go away for 3 to 6 months ignoring things and nothing really got better for you. So we're here for you. There's a lot of very, very smart people who are learning along. We've had 4 BLAs just this month now that surgeries have picked up. So there's always somebody to watch and kind of a partner to go through wherever you are in the process, already had surgery or about to have surgery. So I just wanted to say we're really, we're building our own safety net, and we're kind of all that we have. Is how I feel about it. There's not very many of us at any one place. Even that one study that Dr. Friedman mentioned only had, 87 people? We've got 375. So I think we know a lot that day-to-day things that doctors don't quite know because they don't experience it, but we can definitely help each other and all get smarter. Kind of build that institutional knowledge. So that's it. I don't know where any of that came from, but ta-da. I think anybody else have any questions? If not, I definitely ask in the BLA group. You can contact Dr. Friedman, make an appointment. But we thank you for spending time with us today, Dr. Friedman. We appreciate you so much.